Thank you everybody for joining us today for this webinar about updates to the reporting portal. I'm Lisa Miller. I'm the Data Collaborative Manager with Comagine Health. So I manage the Oregon Data Collaborative, which is the data set behind the reporting portal. I'm joined today by my colleague Tori Scholl, who answers the help desk emails. Many of you have emailed with her before, and she will be helping monitor the chat today. I would like to let you know we're recording this webinar and we will be posting it and making the slides available as well to our website once it's complete. So our agenda today, let's see if we can progress. There we go. I will give a very brief overview of the portal for those of you who are new to it. But we're going to spend the bulk of our time looking at the impact of the update we just made to HEDIS 2020 measure specifications, the impact that has made on the measures that we're reporting in the portal. And then we'll also talk about our measure set review and updates that we conducted in 2020. So you'll see some changes to measures coming this quarter as well as in 2021. And then we have a few miscellaneous updates as well. Please note that a few of you did submit questions ahead of time. Some of those were much more introductory and about how to use the portal. We're not going to be covering that today, but we will be reaching out directly to each one of you who asked about navigation or introductions, and we'll be scheduling a demonstration directly with you. And of course, if you would like a demonstration but didn't ask ahead of time, please reach out to us and let us know that as well. So to begin with, where does the data come from in this database? We receive claims information from the payers in the state of Oregon, almost all the commercial health plans and Medicare Advantage plans as well. 100% of the Medicaid members, and from CMS we receive the Medicare fee-for-service claims as well. We're able to aggregate these into one comprehensive data set that users like you can look through the portal and understand your claims data, your quality results. It also allows comparisons because we are able to capture patients' records over time, regardless of their insurance type. You're able to make comparisons between yourself and another organization as well. Someone did ask how patients are attributed to practices. Claims tell us the provider for each service for each patient, so we get that information in the claims. We then use our methodology to attribute patients to the primary care provider that they've seen the most often for primary care visits in the previous 2 years. It's very similar for women's health. We have OBGYN providers and clinics in here as well. Patients are attributed to the OBGYN provider they've seen the most often in the previous 2 years. So once we have patients attributed to providers, the next step is that we know where providers are affiliated based on the rosters that are present in the portal. So the provider roster in the portal comes from your updates to your own provider roster in the portal, as well as some work that we do to try to keep those updated. But we're definitely not able to get to, especially the independent clinics, and update their rosters. So you can see how important it is to keep your rosters up to date. If we don't have the correct organization for a provider, then those patients are going to be attributed to the wrong organization as well. You can maintain your roster on the providers tab of the portal on the homepage there. And if you need step-by-step instructions, we've got very clear instructions written out. Please go ahead and reach out to us and we'll be very happy to send those to you. All right, in our data set, we have about 80% of the fully insured commercial population, 23% of the self-insured commercial population, 100% of Medicaid, and 87% of Medicare overall. So this gives us about 80% of Oregonians, going back about 10 years. We do not have the national commercial carriers, so Aetna, Cigna, Humana, and United are not represented. Okay, next section. The impact of the update to HEDIS 2020 specifications on the measures. The first set of measures is the antibiotic stewardship measures. So this includes what are now called appropriate testing for pharyngitis, appropriate treatment for upper respiratory infection, and avoidance of antibiotic treatment for acute bronchitis. So some changes to these, on these ones, even the names have changed because HEDIS expanded the age bands to include both children and adults. So appropriate testing for pharyngitis, for example, was previously appropriate testing for children with pharyngitis. But all three measures now include both children and adults. Those age bands are reported separately, so you can look at children separately from adults. The inclusion criteria also changed on these. It was previously restricted to 1 episode per year, and there are no restrictions now. Given that change, the total trend, what you may see in your measures is that they would have decreased because of the increase in the denominator and in inclusion. However, these, because they are expansions of the age bands, these appear as new measures in the portal. So you can't see your trending in the exact same graph, unfortunately. You can always take the previous measures, which are still in there, and look at those results, download those results, and then create your own trending. And if you need any assistance with that, please reach out. We'd be happy to help. Another change to the emergency department utilization measure. Instead of removing ED visits with any diagnosis related to mental health or behavioral health, the new specifications remove only ED visits with a primary diagnosis related to mental or behavioral health. This was the most significant among Medicaid members. So what that led to is an increase in patients who are included in the measure, so therefore the total trend would have increased. And this is data from our demo account. You can see it was a pretty significant change from last reporting period to the current reporting period was a pretty significant uptick. So you may see that in your results as well. Effective contraceptive use changed as well. The new specification includes 60% more codes in the numerator and more exclusion criteria in the denominator. So therefore, the total trend has increased because of both an increase in the inclusion and a decrease in the denominator. In the sample data here, it's not a big increase, but your results at your practice may differ. Follow-up after ED visit for mental illness, both the 7-day and the 30-day follow-up measures. In both cases, intentional self-harm codes were added to the value sets. So the impact of that across all practices, we did not see a change to the total trend because the numerator and the denominator both increased. Your results may differ. You might see some trending up or down rather than a straight line, but we wanted to let you know about the change to the measure. So this is the end of this section. Do we have any questions on the impact of the HEDIS specification updates before we go on to the next section? Tori, was there anything in the chat? Okay. All right, very good. I will continue on. The 2020 measure set review and updates. I'm going to tell you the process we went through and then the results of that review of our measure set. Back in February and March, you might recall you received a survey from me. We surveyed all of our portal users. We took the results of that survey. We asked about each of the measures. Which of these measures would you want us to keep? We took that feedback and we combined it with other feedback that came from some changes that came from the measure stewards, measures that we have required for other Comagine contracts, some additional measures we wanted to suggest because we think they're valuable. And then we also try to stick with and align closely with the Health Plan Quality Metrics Committee standard measures. So HPQMC, if you're not familiar with it, is an Oregon Health Authority committee made up primarily of health plans, but other members, other stakeholders are engaged as well, and they set standard measures that health plans should be measured on in the state for Medicaid, but it is commonly applied across payer types. So we tend to make sure that we are offering the measures that they've adopted as standard as well. So we took all these, we came up with some recommendations, and we reviewed it with our Analytics Advisory Council. The Advisory Council consists of payers, provider organizations, other healthcare organizations, and other stakeholders within the state of Oregon who are interested in helping guide Comagine Health on the analytical kind of detail technical side of the Oregon Data Collaborative. So we had a subcommittee that spent some time in depth looking at each of the measures, and then we rolled their recommendations up and presented it to the entire Analytics Advisory Council, and the decisions were made final at that point. So the result of that review, we previously reported on 59 measures, and we're now reporting on 53 measures. That excludes age bands reported separately. However, you'll see that we retired several measures and we added several measures. So it's more change than just those total numbers would seem to represent. We have yet to identify exactly which new measures will be publicly reported, but we'll notify you well in advance so that you are able to include those in your reconsideration process if you are so inclined. Whenever we introduce a new measure, we wouldn't want to report it publicly right away. We would definitely want to give some period of time, maybe a year, I don't know exactly, but of just reporting it privately to make sure that it feels correct and that provider organizations are able to do their reconsideration periods before it's reported publicly. So the measures group into some specific topic areas. They cover the gamut of everything you might expect to see within primary care, including cost. We have already been reporting some expenditure measures as part of the CPC Plus program, and we're going to be adding some total cost of care measures as well. So a little bit enhancing our cost reporting a little bit as well. We've made the decision to retire several measures. Most of these will be retired in November of 2020, so the next time the portal is updated, these measures will be gone, except in a couple of cases, which I'll mention here. So the first that's retiring is ambulatory care outpatient visits. The reason for this is that there's no accepted standard for whether more or fewer outpatient visits is better or worse. And it just wasn't rated very highly in the portal user feedback as well. People didn't seem to find it very actionable. So that one's going to retire. Annual monitoring for patients on persistent medications. There were 4 measures included in this, so ACE inhibitors or ARBs, digoxin, diuretics, and total. The measure steward actually retired all of these measures. So those have already been retired as of this data refresh. Generic prescription fills, antidepressants, antihyperlipidemics, and antihypertensives. Those 3 measures will be retired in November. We have very high performance just across the board, very little room for improvement. So there doesn't seem to be too much of a point in continuing to report it when performance is so high. Medication management for people with asthma is actually being retired and replaced. So I'll get to that on the next slide. Statin therapy for patients with diabetes, both the adherence rate and the received statin therapy rate, these are both being retired due to low interest from portal users, basically. Use of imaging studies for low back pain, similar reasoning to the generic prescription fills. Compliance with this measure is very, very high across the board, and there wasn't any need to continue reporting on that one. 3 opioid measures retired in August, so have already been retired. Use of opioids at high dosage, use of opioids from multiple providers, and use of opioids at high dosage and from multiple providers. All 3 of these in persons without cancer. The measure steward retired these measures as well. So that's why those retired in August 2020. The measures are no longer being supported. They've been replaced with some different opioid measures. So the new measures that we expect to have available to report on beginning in 2021, we have analysts working on coding these measures currently. And we're not entirely sure of the timeline for when they'll be available, but we do know that they are coming. So first is the asthma medication ratio. That is a replacement for the measure medication management for people with asthma that I mentioned. The asthma medication ratio is the measure that the Health Plan Quality Metrics Committee has decided on as standard. So that's part of what prompted our switch to this other measure as well. We'll be adding colorectal cancer screening. We've actually had requests for this from provider organizations and from payers many times over the years, and it just, we didn't have quite enough history to meet the HEDIS specification, which calls for 10 years of history. I believe by the time we get to 2021, we will have at least 9 years, if not 10 years, depending on the payer. So we will have close to, if not 100% completely, the exact HEDIS specification on that measure as well. And we recognize also that even if it doesn't match the exact HEDIS specification, having some period of long look back for the colorectal cancer screening will still be useful, even if it doesn't exactly match the specification. We've added a new disparity measure as well, ED utilization among members with mental illness. We didn't have very many behavioral health measures. We know, of course, that's a big area of focus everywhere in primary care and in care transformation. So we definitely wanted to add a measure that reflected the needs of this special population. We are going to be adding high-risk medications in the elderly. Similarly, didn't have measures that were reflecting the specific needs of the elderly population, so wanted to add this one. We will be adding the pharmaceutical expenditures measure. That won't come until 2022. That'll be part of the Primary Care First program, but it will be available to all clinics that are able to access the portal. So the opioid replacement measures, we're adding pharmacotherapy for opioid use disorder and risk of continued opioid use. These two measures we believe are going to be able to provide providers with a better sense of how opioids are being used, and the pharmacotherapy one, a better sense of how medication-assisted therapies are being used and spread throughout the state. And then the two cost of care measures that I mentioned earlier, these both come from the Health Partners methodology that we've been reporting on for several years. If you're a clinic that is large enough, you receive cost of care reports from us based on this methodology. So we're planning to start reporting on these two indices in the portal as well. So the first will be total cost of care at the population base. So total cost of care essentially is resource use times price equals cost. There's a whole long methodology that goes into figuring that out, but in the high level is resource use times price equals total cost of care. And then we'll also be reporting one of those aspects, which is the total resource use. So how much utilization is your patient population gathering. Those are both reported as a per member per month index. Any questions before I go on to the next section? That was the end of the what's coming up next year.
Yeah, we received a question in the chat about the statin therapy for patients with diabetes measure and the use of imaging studies for low back pain. They are currently in the portal right now, being retired in November. So does that mean that folks don't need to worry about submitting reconsiderations for those measures because they'll be pulled?
It's a great question. We love explaining the reconsiderations timeline because it's not complicated at all. You do need to submit reconsiderations on those measures if those measures are publicly reported, which I don't know off the top of my head. Tori, perhaps you can look quickly on Compare Your Care and see if those two are publicly reported. So there's two major buckets of reasons why clinics decide to submit reconsiderations. One is because they want to correct and make sure that any results that are being reported publicly on Compare Your Care are as accurate as is possible. So that's what Tori's going to check for us on these two measures. The other reason that organizations submit reconsiderations is if they are working on internal quality improvement activities that use those measures. And then they would feel motivated to correct the data in our portal so that the reporting that comes from the portal is as accurate as possible. So those really are the two major buckets of reasons why people want to correct their reconsideration or correct their measures in the portal. So we'll come back to that once Tori's had a chance to take a look on Compare Your Care and see if those are public.
Yes, so it looks like both of these are going to be publicly reported for 2020.
Okay.
Yep.
So, so what that means is Compare Your Care runs about a year behind reality. So we just, well, in December of this year, we'll be posting results for calendar year 2019 to Compare Your Care. The reason for that is because we need, obviously we need the full year of claims in, but we also need to allow time for the full year to go through the reconsideration process with providers. So the reconsideration process that's open right now and open for another month, you have until October 29th, I believe. What you're reconsidering in there is your calendar year 2019 data plus the 3 months prior to that. We only open reconsiderations every other reporting period just to try to reduce the burden on both of our ends of that reconsideration process. So we open 15 months at a time. The final quarter of 2018 you would have already reviewed. We may have gotten in some more claims after that quarter was reviewed, which is why it's open again for reconsiderations. But for the purpose of our conversation right now, let's just focus on the calendar year 2019. So we have those claims available in the portal right now. That's what's available, and that is what you're reconsidering. Reconsiderations will close October 29th. We will, as you guys submit reconsiderations, they're being processed for the most part. They're being approved, denied. We're communicating with you if we need more information on any of them, etc. As we, once reconsiderations close, then we are able to make sure all of them have been processed, either approved or denied. And then our technology partner works with us to incorporate those reconsidered results back into the data, so that when we produce the calendar year 2019 results for Compare Your Care, it includes the reconsidered, the corrected data that you all submitted. So that's why it takes such a long time. It takes a long time to get the data in. It takes a long time to do to allow organizations to do the reconsiderations, and then it takes a while to get the reconsidered results back into the data so that it's ready for reporting. Bottom line, if you want to correct the data that's going to be reported for calendar year 2019, you should do reconsiderations for those measures that are in the portal right now. I'll give you a hint too. An easy way to tell if they are publicly reported is to go onto the reporting tab, and when you filter for measures, if you look for the measure group, you can see publicly reported is one of the measure groups that we've created for you, so that you can then view just the publicly reported measures as a quick way of figuring out which ones will be publicly reported. Long answer to a seemingly simple question. Thank you.
And I did I mentioned this in the chat, but I want to confirm that I misspoke. The statin therapy for patients with diabetes is not publicly reported. The use of imaging studies for low back pain for age 18 to 50 is publicly reported. And I've provided the link to our website with the document that lists the publicly and privately reported measures for 2020.
Great, thank you, Tori. What other questions have come in? Oops. Okay, I guess I will move on if there aren't any other questions. There we go. So just a few more updates. Talked about reconsiderations already. The next data refresh, I've mentioned this a couple times, but that's expected mid-November. That will be on the Q1 2020 data. So this will be the first set of COVID-19 data that we're reporting. There was a question before the webinar in the registration questions about whether telehealth data would be reflected in the data that's being reported. Since COVID began, we have been ramping up the list of codes that are for telehealth claims. And everyone, all APCDs across the country have been trying to ramp up that list. So we have a very good, very comprehensive list. So they should be included, beginning with probably the March 2020 data. It wouldn't necessarily be reflected accurately in January and February. But definitely by the time we get to Q2, when we were well into the pandemic, the telehealth claims will all be reflected in there as well. We've been looking at, just as an aside, we've been looking at doing some analyses specifically about telehealth and the adoption of it as well. So we're hoping that we get an opportunity to be able to publish some of that information. Another update we wanted to let you know that if your practice is one of the practices that receives total cost of care clinic comparison reports from us, those are available now in the portal. This is for practices that have at least 600 either commercial or 600 Medicare fee-for-service patients attributed to them by our attribution methodology. Then they receive an annual cost comparison report. That's from the portal's homepage on the left-hand nav bar under documentation, then in reports. So those are searchable. And please, if you have questions about those or would like to talk through your cost report, we'd be very happy to do that. And please reach out to us and let us know. Okay, any questions, or we have plenty of time. So are there other topics that people would like to bring up or ask about? All right, I will take that as a no. Thank you all for joining us. We'll get the recording and the slides posted when we're able to, and we greatly appreciate you taking the time to join us today. Talk to you all later. Goodbye.
Thank you.